Imagine you're walking down a hallway.
Yeah.
In a typical layout, the door you're looking for is tucked safely off to the side, so you can walk straight down the hall without ever running into it.
Right. It's out of the way.
Exactly. But what if the floor plan was completely different? Like, what if that door was placed dead center, right at the very end of the hall, sitting directly in your line of traffic?
You'd walk right into it.
You would. And the wild thing is, for about 20 to 30% of women, their internal reproductive anatomy is built exactly like that second hallway.
Yeah, it's a massive demographic. I mean, we're talking about millions of people living with this specific anatomical structure.
Right.
Yet it is rarely discussed, outside of a sterile, highly clinical setting. And because of that silence, the physical realities of living with it are often completely misunderstood.
This is exactly why we're doing this deep dive today. We are pulling from this huge stack of medical guidelines, clinical anatomy reviews, and specialized physical therapy resources to answer a highly specific question for you, the listener.
And it's an important one.
It really is. We're asking, can a tilted uterus fundamentally change how the vagina feels during sex? And perhaps more importantly, can that structural difference be the direct cause of pain?
Yeah, because historically, if a patient reported sexual pain, the medical community well, they didn't have the best track record.
No, not at all.
The pain was often dismissed or minimized or incorrectly labeled as a purely psychological issue, like an anxiety response or just a lack of relaxation.
Oh, it just adds a whole layer of guilt to the physical discomfort. You're basically told the problem is all in your head.
Exactly.
When in reality, as we're going to explore today, it's often just baseline geometry. So our goal is to give you a roadmap for relief based entirely on the physical mechanics of how the body is actually built.
I love that. Baseline geometry.
Right. So let's start with that baseline. What does it actually mean, medically speaking, to have a tilted or retroverted uterus?
So to visualize the difference, we really have to look at the standard orientation first. Normally, the uterus leans forward. Okay. It rests kind of over the bladder, pointing toward the abdominal wall. And in clinical anatomy, this is called an anteverted uterus.
Anteverted meaning forward.
Right. But in roughly 1 in 5 women, the uterus develops tilting in the exact opposite direction. So it angles backward toward the lower spine and the rectum.
Wow. Okay.
And that backward tilt is what we call a retroverted uterus.
But the sources we read make a really strong point to emphasize that this backward tilt isn't like a defect.
Oh, not at all. It is a completely natural anatomical variation. I mean, the best comparison is just being left-handed.
Oh, like that.
Yeah, it's just a different baseline configuration. A developmental retroverted uterus is not dangerous, it doesn't impact fertility, and honestly, for many people, it causes 0 symptoms.
So you could just never know.
Exactly. You could go your entire life never knowing your uterus tilts backward until, an ultrasound technician happens to mention it in passing.
But for those who do experience symptoms, specifically pain during intercourse, the distinction matters immensely.
It really does.
The clinical anatomy sources we reviewed, they break down the axes of the pelvic organs to explain this, and they mention things like the posterior fornix. So how does a backward tilt physically change the internal landscape of the vagina?
Well, it drastically alters the relationship between the vaginal canal and the cervix. So with a typical forward tilting uterus, the longitudinal axis of the uterus sits almost at a right angle to the vagina.
Okay, a right angle.
Yeah, and because of that sharp angle, the cervix, which is the opening to the uterus, is tucked away in this little space at the back of the vaginal canal known as the posterior fornix. It basically points downward and backward.
So that right angle naturally pulls the cervix out of the direct line of penetration. It creates like a physical buffer zone.
Yes, exactly. But when the uterus is retroverted, that protective right angle essentially vanishes. The axis of the uterus lines up much more parallel with the axis of the vagina.
Oh, wow.
Yeah. As the body of the uterus leans backward against the spine, it acts like a lever, and it literally pushes the cervix forward.
Pushes it forward.
Right. The cervix becomes anteriorly placed, resting much closer to the bladder and urethra.
So going back to our hallway analogy, the door is no longer tucked around the corner. It's facing you head-on at the very end of the hall.
Precisely.
Now, if we're just looking at a static anatomy diagram, sure, that makes perfect sense. But intimacy isn't static, it's dynamic. So if that door is sitting right at the end of the hallway, what happens when things start moving? Like, does the body have a defense mechanism for that?
It does, but to understand how it works, or, how it fails to work, we really have to look at the physiology of arousal.
Okay.
And this brings us to a mechanical concept known in the medical literature as collision dyspareunia.
Dyspareunia. That's the clinical term for painful intercourse, right?
Exactly. And collision describes the exact physical mechanism here. Because the uterus is tilted backward, the cervix, ovaries, and fallopian tubes are all tipped back right along with it.
Ouch.
Yeah. So deep thrusting can result in a literal physical collision with these highly sensitive structures.
The sources reference the classic Masters and Johnson studies to explain this, which is fascinating. Because before their lab observations, doctors didn't actually have a clear picture of how internal organs moved during the sexual response cycle.
They really didn't. It was a huge blind spot.
So what did those studies reveal about the mechanics of the vagina?
They documented that the vaginal canal is incredibly dynamic. It isn't just a fixed tube. As arousal builds, the upper end of the vagina naturally lengthens by about 3 to 4 centimeters.
Wow, that's significant.
It is. And the entire canal widens to a diameter of 6 centimeters or more. The body is literally actively creating space.
It's almost like a telescoping lens extending outward.
That's a great way to picture it. And alongside that telescoping effect is a process called tenting.
Tenting.
Yeah. In a typical forward-tilting pelvic layout, building arousal causes the uterus to elevate. It literally lifts up and out of the lower pelvis, moving in a cephalid direction.
A cephalid, meaning it's pulling itself upward toward the head.
Upward toward the chest cavity, yeah. The entire structure elevates. So this combined process, the vagina lengthening and the uterus pulling itself upward, it serves a very clear physiological function.
Which is?
It pulls the cervix farther away from the vaginal opening. It's moving those sensitive structures out of the way to prevent that exact collision we just talked about.
Okay, here is where the mechanics get really critical, I think. If a retroverted uterus is already leaning backward against the spine, what happens to that telescoping tenting mechanism?
It fundamentally changes the trajectory of the expansion. Because the retroverted uterus is anchored backward, the natural lengthening of the vagina tends to occur more anteriorly.
So in the front.
Right. In the space between the bladder and the uterus. The uterus doesn't achieve that same cephalid lift. It just doesn't pull up and away from the vaginal canal in the same protective manner.
So the cervix basically stays exposed. The defense mechanism doesn't clear the hallway.
Exactly. It leaves the cervix squarely at the end of the hall, making it highly vulnerable to impact.
I want to pause on this for a second because it leads to an incredible insight from one of our physical therapy sources.
Oh, the Raquel Perlis paper.
Yeah. If the body needs ample time to trigger that telescoping effect and create whatever space it possibly can, does that mean, like, skipping foreplay is a literal mechanical failure for someone with a tilted uterus?
It is a guaranteed recipe for collision. Raquel Perlis, she's a pelvic floor physical therapist we pulled from, and she specifically highlights this. If penetration occurs before full arousal is reached, the pelvic organs are sitting at their lowest baseline point.
Right.
And the vaginal canal is at its absolute shortest.
So for the 30% of women whose cervix is already sitting head-on in the line of traffic, extended foreplay isn't just about, getting in the mood.
No, not at all.
It's a physiological requirement. You are literally waiting for the internal organs to physically move out of the way.
It is a mechanical necessity. If you bypass that physiological warm-up, you are forcing deep thrusts into a shortened canal where the cervix is completely unguarded. I mean, pain is the inevitable biological response.
That honestly reframes the entire conversation around sexual pacing.
It really does.
But okay, even with ample foreplay, the geometry is still fundamentally different, which means we need to talk about the relief roadmap. If a listener has this anatomy and experiences collision pain, how do they navigate it?
Well, the primary strategy is positional adaptation. You essentially have to adapt the angles of intercourse to match the internal geometry. And the first step is knowing which positions are notorious for causing this specific collision.
Okay, what are the worst offenders?
The clinical guidelines consistently flag 2 primary positions: deep rear entry, often called doggy style, and the woman on top position.
Wait, hold on. Doggy style, I understand because of the angle.
Yeah.
Like if the uterus is tilted backward toward the spine, rear entry is driving directly toward that exact location.
Okay.
But woman on top. If the person with a tilted uterus is on top, they dictate the pace and the depth. Shouldn't that be the safest position to prevent a deep collision?
You would completely assume so because of the control factor, but you have to account for gravity and momentum.
Ah, Gravity.
Yeah. When the receiving partner is on top, their entire body weight is basically bearing down on the pelvis.
Hmm.
Gravity facilitates a very deep, sudden impact. Even if you're trying to control the pace, a slight shift in momentum can drive the cervix forcefully into the partner.
So it's less about the angle itself in that case and more about the uncontrollable depth caused by gravity.
Right. The momentum easily overrides the muscular control. And the sources point out that vigorous collision in these positions isn't just uncomfortable, it can actually cause physical injury.
Injury, like actual tissue damage.
Yeah. The uterus is held in place by several bands of tissue, including the uterosacral ligaments. Repeated deep impact against a retroverted cervix can actually overstretch or micro-tear those ligaments. Yeah, and that results in a deep, radiating pelvic ache that lasts long after intercourse is over.
Ligament tearing. That's a stark reminder that this isn't just like psychological anxiety, it's a structural injury.
Exactly.
So if deep rear entry and gravity-heavy positions are the main culprits, what are the recommended mechanical fixes?
It's all about changing the trajectory and limiting the depth. So front entry positions, like the traditional missionary position, are often significantly more comfortable.
Why is that?
The specific angle of the pelvis in front entry naturally points penetration toward the front wall of the vagina. So it aims the trajectory away from that backward tilted cervix.
Okay, so you're essentially pointing the traffic toward the side of the hallway instead of straight down the middle.
Perfect analogy, yes.
What else?
Shallow entry positions are highly effective. Side lying or spooning is heavily recommended in the physical therapy literature.
Oh, because of the hips.
Right. When both partners are lying on their sides with their hips aligned, the mechanics of the human skeleton naturally restrict how deep penetration can go. It physically prevents the kind of deep thrusting that leads to a cervical collision.
Okay, but what if a couple prefers a position like rear entry? Does the physical therapy source suggest they just have to abandon it entirely, or are there ways to modify it?
This is where microadjustments come into play, which is super practical. Raquel Perlis suggests that if you are using a rear entry position, the receiving partner can keep their thighs close together rather than spreading them apart.
Wait, how does that change the internal mechanics?
Well, closing the thighs shifts the angle of the pelvis and restricts the forward mobility of the hips.
Oh, interesting.
Yeah, it basically creates an anatomical barrier that limits penetration depth without having to completely change the dynamic of the position.
That's incredibly simple.
Right. And another incredibly practical tip she offers is creating a manual bumper.
A bumper?
Yeah, a partner can literally place their hand at the base of the penis during intercourse.
Oh, I see. So they are acting as a physical stopper on the door.
Yeah.
It literally stops the momentum before the collision can happen deep inside.
Exactly. It's an immediate physical safeguard. It
Yeah.
requires open communication, obviously, like saying, hey, let's keep the depth shallow here. But it puts the person experiencing the pain in total control of their anatomical comfort.
I love that. Now, we've been talking about this as a purely structural baseline geometry issue. You change the angle, you use a physical bumper, and the mechanical pain is solved.
Right.
But we need to pivot here because the medical guidelines highlight a very different scenario. What if the pain isn't solved by a new angle? Like, when is a retroverted uterus a red flag for a much larger problem?
This is definitely the most crucial distinction for you, the listener, to make. Everything we've discussed so far involves a developmental retroverted uterus. You were simply born with that left-handed geometry. But a uterus can also become retroverted later in life. We call this an acquired retroversion.
Acquired, meaning something caused it.
Yes. It happens when an underlying pathology creates dense scar tissue or adhesions inside the pelvic cavity. And those adhesions physically latch onto the uterus, drag it backward, and basically cement it into a retroverted position.
So the tilt is no longer a natural variation. The backward tilt is actually a symptom of disease.
Exactly.
How exactly does a disease pull a whole organ backward? What are the conditions doing this?
The two most common culprits are endometriosis and pelvic inflammatory disease, or PID.
Okay, let's look at the mechanics of endometriosis first.
Sure. So endometriosis occurs when tissue that's similar to the lining of the uterus starts growing entirely outside of it, like on the ovaries, the fallopian tubes, the outer wall of the uterus, or even the bowel.
And because it's similar to the uterine lining, it responds to the menstrual cycle, right?
That's the core issue. Every single month, this rogue tissue swells and bleeds. But unlike the lining inside the uterus, which, exits the body during a period, this internal bleeding has nowhere to go.
Oh, wow.
Yeah. It just pulls in the pelvic cavity. So the body's immune system recognizes this as an injury and triggers a massive inflammatory cascade to heal it.
Which means scar tissue.
Exactly. It lays down these sticky proteins like fibrin, which harden into dense bands of scar tissue.
So the body is essentially building like internal webbing to patch up the bleeding.
Yes,
Yeah.
and that webbing, the adhesions, can act like superglue. It can adhere the back of the uterus to the colon or the spine, literally pulling it out of its normal position and tethering it backward.
That sounds excruciating.
Yeah.
What about pelvic inflammatory disease? How does PID alter the geometry?
Well, PID is a severe infection of the upper reproductive system, most frequently caused by untreated sexually transmitted infections like chlamydia or gonorrhea.
Okay.
The bacteria travel up through the cervix and infect the uterus, fallopian tubes, and surrounding organs. And just like with endometriosis, the severe infection triggers massive, widespread inflammation.
Some more scar tissue.
Right. As the body fights the infection, it leaves behind widespread scarring that can distort the entire pelvic architecture. It literally pulls the uterus into an acquired retroversion. And actually, uterine fibroids and large ovarian cysts can also physically weigh down or push the uterus out of alignment in a similar way.
So if the end result, a backward tilting uterus, is basically the same, how is a listener supposed to know the difference? If someone is experiencing pain during sex, what are the specific red flags that signal, hey, this isn't just my natural geometry, this is an underlying pathology?
The nature of the pain itself is your most reliable gauge. With a naturally tilted uterus, collision dyspareunia usually presents as a dull, deep ache.
Okay, dull and deep.
And it happens immediately upon deep impact. Crucially, it goes away or significantly improves the moment you change positions or restrict the depth.
Because you've removed the mechanical trigger?
Right. But if the pain is sharp, stabbing, or searing, that is a red flag. If the pain is new, meaning, deep penetration used to be perfectly comfortable for years, but now it suddenly causes agonizing pain, that is a massive red flag.
Right, because your baseline skeletal and organ geometry doesn't just suddenly alter itself overnight.
Exactly. An abrupt change means something in the internal environment has changed.
Are there any other red flags to watch out for?
Yeah, other urgent red flags include pain that progressively worsens month over month, or if the sexual pain is accompanied by systemic symptoms,
Like what?
like abnormal or heavy vaginal bleeding, unexplained fevers, severe lower back pain that feels like a constant tethering, or experiencing sharp pain during normal bodily functions like urinating or having a bowel movement.
Oh, because of the adhesions.
Right. If the uterus is glued to the bowel by endometriosis, a bowel movement will physically pull on the uterus, causing pain.
That makes total sense. So if a listener is checking these boxes, changing sexual positions obviously isn't going to fix the root cause. What does the medical treatment pathway look like for an acquired retroversion?
Well, the treatment must target the underlying disease. If the adhesions are mild, conservative therapies like specialized pelvic floor physical therapy can really help relax the surrounding muscles that have basically gone into chronic spasm from the pain.
But for more severe cases?
For severe cases, the treatment is heavily medical.
Medical in what sense? Like drugs, surgery?
Both, honestly. For severe endometriosis, physicians will often use hormonal medications to induce a temporary reversible menopausal state.
Wow, okay.
Yeah, by shutting down the hormone production, you starve the rogue tissue and stop the internal bleeding and inflammation. In those complex cases, doctors carefully administer hormone replacement therapy, or HRT, to protect the patient's heart and bone density while the endometriosis is being suppressed.
But what if the scarring is already there, acting like superglue? Medication can't just dissolve that, can it?
No, it can't. Established scar tissue usually requires surgical intervention. A surgeon will perform a laparoscopy using tiny instruments to enter the pelvis, identify those bands of scar tissue, and physically cut them to release the tethered organs and restore the uterus to a mobile, natural position.
Okay, let me just synthesize the main takeaway here, because I think it's so important for anyone listening. If adjusting your physical angle or limiting the depth of penetration entirely resolves the discomfort, you are likely just navigating your natural left-handed anatomical geometry.
Exactly.
But if the pain ignores your positional changes, if it's a new development or if it's accompanied by other systemic symptoms, your body is sounding an alarm. That is the moment to stop adapting and seek a medical evaluation.
Absolutely. I mean, pain is a communication tool. A dull ache from a collision tells you to adjust your mechanics. But sharp, persistent, or new pain is a warning signal about your internal environment. It is never something you are expected to silently endure.
We have covered a tremendous amount of ground today. I mean, we took the dry clinical data regarding pelvic axes and translated it into real-world mechanics.
Which is so needed.
It is. We've established that, yes, a retroverted uterus fundamentally changes the internal landscape, and it can absolutely cause deep penetration to feel uncomfortable. But the biggest takeaway is that for the millions of women with this natural anatomy, it is highly manageable.
Highly manageable.
Communicating with a partner to control depth, utilizing physical bumpers, and prioritizing arousal aren't just like vague relationship tips. They are practical, mechanical solutions to a geometric reality.
And, when you look at the human body through this mechanical lens, it highlights just how dynamic our internal structures really are.
Oh, absolutely.
And there is one final detail from our clinical sources that perfectly illustrates this, which I think you'll find fascinating.
I always look forward to these hidden gems in the research.
Yeah.
What did you find?
Well, we've spent this entire deep dive discussing the retroverted uterus as a fixed geometric state, a door permanently installed at the end of the hallway.
Right.
But that architecture can entirely rewrite itself under the right conditions. Consider what happens during pregnancy.
Oh, interesting. What does happen?
The sources note that during the first trimester, a naturally retroverted uterus will almost always correct its own angle.
Wait, really?
Yeah. As the baby grows, the uterus physically lifts itself up, shifts forward out of the pelvic cavity, and assumes a standard anteverted position.
It just spontaneously remodels the hallway to make room.
It completely reorganizes its structural baseline, and then, quietly, in the weeks or months following birth, it will simply fall right back into its tilted backward position as if nothing ever happened.
That is incredible. It just reverts right back to its original left-handed state.
It really is, and it leaves you with this profound question to consider. If our heavy internal organs can dramatically reshape their baseline geometry for a few months, operate in a completely different configuration, and then silently revert back to their starting positions, what other subtle structural shifts might our anatomy be making throughout our lives entirely without us ever noticing?
Wow. It certainly shatters the illusion of those rigid textbook diagrams we talked about at the start. The human body is not a static machine built from a fixed blueprint. It is a shifting, living landscape. And sometimes avoiding the pain of navigating it simply requires understanding where your doors are actually placed.